Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everybody. Welcome to Interdisciplinary Case Miles. Thank you for joining us today. Hi, Kelsey. Hi, Sarah.
Hi. Hi, Kate.
Today's case is going to be a 41-year-old female, and she's actually going to present to Kelsey first. So she's presenting because she's undergoing some changes in her body. She's in that perimenopause or menopause transition, and she wants to know what to do nutritionally. She's not really sure how to handle these changes. She's a half marathoner, so she's running quite a lot of miles. She's never had any children. And then when she's with Kelsey, she actually just happens to mention that she has a little bit of intermittent low back pain. She is a female physician who is on her feet all of the time, and she's under quite a bit of stress because of her job. So go ahead, Kelsey, take it away.
Yes. So this client first starts working with me because despite feeling like she's not exercising less or eating more, she's noticing some body changes, which prompted her first reaching out to me. And then I always ask about sleep with my clients. And so we also kind of, identify that she's not getting the best sleep, could be job related, could be hormonal changes given where she's at. And then, yes, like Kate said, she just randomly mentions that she has some back pain. But before we talk about the back pain, I think what's relevant in this setting of working with healthcare providers, oftentimes they're going a really long time without food just because of the access to the food, or they're just simply have really important things going on in their day. So they just simply forget to eat. Also, we do know that in menopause that there's changes with estrogen and other hormones too, but estrogen being one of the ones that I know you guys can speak to a little bit more, but changes things like collagen, tendons, muscle recovery, certainly the other hormones that are on the top of my head too, testosterone, progesterone, which is starting to diminish a little bit, also can impact sleep quality. And so what I would want to first, my first approach would be, okay, what is some of the messaging that you've heard about menopause nutrition or perimenopause nutrition? Because there's a lot of messaging. And yes, we do need to eat a little bit more protein, but a little bit more protein doesn't mean stop eating carbohydrates. And then also, I think that it's very real that we need to be talking about more that bodies are meant to change. And I think that this client, not having experience of body change due to childbirth or anything like that, this is one of the major first times that a client like this is experiencing body change. And while it's uncomfortable and we don't have to be body positive, a big kind of hat that I encourage my clients that are going through changes is body neutrality, which means that, hey, we cannot like these body changes, but is there any way to be a little bit more neutral about it and really focus on the function of our body? Because sometimes body positivity is just an unrealistic ask. If you feel body positive, great, love that for you, but you're not going to feel that way 365 days out of the year. So that's one of the first things that we really, really talk about. And then talk about too, just because your body's changing, that's a poor indicator of whether we're meeting nutrition needs and supporting our body. We're more wanting to look at metrics such as, in her stressful job, what are her energy levels like? What is her tolerance of this stress like? Are we sleeping a little bit better? What's the recovery like when she's recovering from her harder half marathon training? With the sleep, I think that sometimes when someone's not sleeping well, before we even touch like more performance-based nutrition, I'll see if there's anything that we can do with sleep. Some strategies, basic sleep hygiene, things that may or may not have to do with food. I would be curious about, has she tried magnesium? Specifically magnesium biglycinate or threonate is most impactful for sleep. There's also some other herbs. Again, everybody's brain chemistry and reasons why they're not sleeping is a little bit different, but valerian root, chamomile, those kinds of herbs can be helpful. And then also there's another B vitamin called inositol, which has more of a role with hormones that can sometimes be appropriate. Working with someone like myself or a physician with using inositol is important though, because it can influence your blood sugar too. And so, yeah, I would be wanting to reel in the sleep first. And then I would want to see if there's any crevices in her day where we can make sure that we're eating every 3 to 4 hours. That way we're making sure that hormones are being supported. And that's going to be easier if our relationship with the size of our body is more neutral. So back pain, I think that I will go ahead and send this to Sara in terms of what you would do.
I love it when you start cases like this because it really reminds me why I like working with you so much, because you've already done most of the things I would have done, which is fantastic. And it means you're supporting those same things when I send you patients that I've already talked about them too. So absolutely, if you're not sleeping, nothing else really matters yet, right? So addressing from a really comprehensive standpoint. So from the low back pain standpoint, musculoskeletal, there's a few different ways that we can look at back pain. Usually it's not happening in isolation, and oftentimes it's kind of like when we talked about plantar fasciitis, where people kind of tolerate it for a while until they roll over at night and it wakes them up, or there's something that it starts interrupting during the day, or they start having painful runs because that's just not tolerable, right? And so oftentimes it goes on longer than we would like. And oftentimes at that point, we have some really deep-seated biomechanical issues and other things that are going on. When folks aren't having radiating pain, we call this more axial pain. So pain that's just happening directly in the back. And this could be a lot of different things. This could be some arthritis. This could be a disc bulge. It could be certain postural patterns that have made certain muscles tighter than others. Someone with scoliosis might have some chronic issues with pain. And as they get older, might have some other changes that happen in their back with regards to the angles in their back as well. So a lot of different things that we look at. This is definitely a patient I'm getting a comprehensive kinetic chain evaluation on to figure out what exactly is driving the back pain. Do they know how to use their core? And is it turning on when they need it? So even looking, if they say, I've been doing all these exercises, I say, well, show me some of them and let's take a look at how things are actually activating. Are they holding their breath while they're doing the exercises? And Kate's laughing right now too for the same reason I said before. So a lot of different things that we want to look at in terms of how they're actually using their body. The type of physician might matter as well. So is this someone who's having to actually do a lot of manual labor? Is this a surgeon, an orthopedic surgeon, the OR, someone who's having to wear a lead vest? Did they just transition to a new job where they didn't wear a vest before and now they do? So a lot of things in the workplace certainly that could impact this as well. So I will oftentimes get some screening x-rays for these folks if they want them. Sometimes we don't see anything at all and everything looks just fine. Other times it gives us kind of a ballpark of what's going on in the back, but it's not usually super specific. And so there's kind of limited value in the x-rays that we might get from this from my standpoint, because the first thing I'm going to do is send them over to Kate and have her start working with them from a physical therapy standpoint, making sure that the body's really helping to support the back. If they do give me really specific symptoms, some things that I worry about are things like a pars stress fracture. So someone who's doing a lot of hyperextension through their back, they can have a stress fracture, and we treat that a little differently. Or if they're having pain radiating down their leg, or if their neurological exam is abnormal, red flags like bowel or bladder changes could also signal some major things going on in the back. So if they're passing all those screening tests and there's nothing really glaring that's concerning that needs immediate workup, I will oftentimes take these things slow and really focus on kind of the comprehensive holistic standpoint like Kelsey mentioned, and then make sure we're getting into PT and really optimizing function that's helping to support the back.
Well, I really like to get somebody after they've seen both of you. It's so delightful. Definitely sleep again. You mentioned it, but I'll ask about it. And I often go through their entire sleep routine. And if there's somebody like this who's probably their brain is going on and on and on and they can't shut it down at night,
Can't imagine what that's like.
I know. I don't think any of us know. I will have them journal before bed. So to just dump their thoughts out before they go to bed. And that's part of their sleep routine. So just kind of touching on how I might manage that, but I'll definitely go through that. And then again, if this has been ruled out as a disc herniation with radiating issues, then it would be, I would call it like maybe non-specific back pain or axial pain. Then I would approach it in a couple ways. I always do check, reflexes, all of that kind of thing when they first come in, even if they've been to somebody else, to make sure that we haven't missed anything. But I'm going to look and ask questions about pelvic floor, even though this, and I wanted to specifically say for this athlete, because she has not had a baby, never been pregnant, it still needs to be a question on your evaluation, because pelvic floor dysfunction can happen whether or not you've had a child before. And so I'm going to ask questions about stress urinary incontinence. I'm going to ask questions about urgency. I'm going to ask if she has any pain. I'm going to just kind of see, like, what is her breathing pattern? Is she holding her breath? Is her breath all up at the top here instead of in her diaphragm? Is she unable to breathe through her rib cage or her thoracic spine? Is she holding her breath when she's doing exercises? I'm going to look at what does her core, she says she's doing core work. Well, what does that mean? And what does it look like? Oftentimes this happens to my friends that I will be like, well, what do you mean you're doing something? And then I'll make them show me and I'm like, oh God, no. And that's because I want to make sure that they're laughing, because this has happened to both of them. I'm really sorry. I can't help myself. Okay, so we're going to make sure that she's, how is she breathing? How is she engaging that core? Is she able to maintain that core stability when she's doing other things? And then how are we going to, oops, I hit my microphone. I'm getting very excited over here. So how are we going to progress that on, right? So there are a lot of different things. And, is the question, another question I always get is running causing my back pain? Maybe, maybe not. So if they don't have good hip extension, if there's a lot of tightness in their anterior hip, so like hip flexors, quads, things like that, then it's going to create some, she's not going to be able to extend her hip back. So she might be extending through her lower back when she's running. And so working on that running posture, making sure that her hip mobility is good, is going to offload that back pain. And then again, if she's sitting a lot, I know she's up, like this athlete is actually up during work a lot, but if she is sitting and getting pain with sitting, I'm going to think about, like, are her knees higher than her hips? Are hips, higher than her knees? Typically, we want our hips higher than our knees so that we can get a better core activation without having to think about it. And what does the neural mobility look like? So what does the hamstring length look like? So we're going to look at all of those different things. Like we always look at a million things, but I think those are the most important piece. And of course, if this is someone in the perimenopause place or menopause transition, we do have to think about the hormones. And so I might send them to Sara to talk about that, or I might send them to like another physician that really focuses on that for female athletes.
Yeah, one thing I wanted to mention is activity. A lot of times people say, should I be running? Like, what do I do during this time frame? And so, really talking about activity modification based on what pain is like. If you have no pain during the run, but your pain spikes afterwards, I would consider that the running is potentially flaring pain. I think also looking at what is a major cause. Is the running itself causing pain, or some of the habits at work, posture, that sort of thing, causing pain? Because sometimes shutting down completely will make back pain feel worse. So keeping them as active as they can while avoiding flaring their pain, I think, is really helpful. So sometimes I'll have them switch to something that reduces the high impact, so that it's not bothering them, especially if this is more disc related pain, which you can have disc pain without having nerve pain radiating down the legs. And certainly that type of pain can be worse afterwards. So I usually will try to kind of troubleshoot and figure out, how do we keep you active, but also minimize how much pain is flaring? The other thing that I wanted to mention at this case as well is sometimes I'll have patients that we just can't quite get rid of that little niggle. And folks can, they go through PT and a lot of things are really checking out and doing fine. And they come back to my office over and over, and, we work things up. We rule out the scary things. We can certainly get MRI and make sure there's nothing else that we need to be worried about. But when I don't have other red flags and things are just kind of sticking around, I always remind them, number one, it can take quite some time to change mechanics and really make sure core is engaging and everything else is falling into place. But sometimes it's okay to have a little bit of discomfort, finding ways to manage that, but not shutting down your whole life because there's some discomfort there. I certainly don't think that we should ever completely deny sensations in the body, but I think how much we attribute to it and decide if it's going to stop our activity is really important. So I always have those conversations very carefully because I want to make sure patients understand I don't want to write off their pain in any way, shape, or form. But occasionally, pain can be something that we just want to watch it and it's there. And if you can run and you feel okay during and after, and it just kind of bothers you when you roll over a little bit as you're getting ready to go to sleep and then that'll wake you up and you're doing okay otherwise, we don't necessarily have to throw the kitchen sink at it and throw procedures at it. But sometimes those folks I'll see every 3 to 6 months or so. And we kind of check in, just make sure nothing's changing. But I think it's also valuable to realize sometimes as we get a little bit older, we get these niggles that just don't entirely go away. And that can be okay. But again, that mental health standpoint, I think, is so important.
Yeah, and I would also ask about their pre-run and their post-run activity, or maybe pre-work, post-work activity, so that if they are going for a run and they feel like it's worse after, if they're not really doing anything after to help, that might be the reason. It might not actually be that they can't run. And so I do like to dig into that on both sides. Like maybe we need to do some standing clams or some kind of glute work before we start running. And then maybe we need to do some more mobility, like stretching out your hip flexors after running. And sometimes just adding those.
You don't want to do clamshells on your side?
Oh my God, here we go. I knew it was going to come up. No, never. Just kidding. Ha ha ha. But I think that sometimes adding those two things can make a world of difference to someone's quality of life and their ability to do the thing that they love. So, all right, ladies, I think this is a good point to wrap it up. And I would like just give me your 1-2 favorite things from this conversation. Sara, you can start. Take homes.
Yeah, so I think kind of differentiating generalized local back discomfort, which this may sound like different things, but pain that's just in the low back versus pain that's radiating elsewhere or causing, any kind of red flag symptoms. We treat it relatively differently, and we can tolerate that more generalized sensation a little more and stay more active and not necessarily shut everything down. But we still want to treat it because that pain can get worse, and it could also progress to a disc bulge and nerve pain in the future. So we want to really protect our backs.
Kelsey?
Yeah, I think that not judging your nutrition based off of if your body is not changing or changing. I think that you don't need to give yourself the idea that you're doing anything wrong just because your body's changing. That's a normal part of life.
Great. And I'd like to say just because you haven't had a baby in the past doesn't mean your pelvic floor is not part of the equation when it comes to low back pain. So you definitely need to have that addressed. And if you have pain with running, maybe we look at your strategies before running and after running and make sure that we're looking at that hip extension and hip mobility component in addition to the low back. All right. Well, thank you so much today, ladies. This has been fun. Thank you, everybody, for listening and staying with us here. And if you like this podcast, please follow us, share it, give it to your friends, your coaches, your other running partners. And if you haven't heard other episodes, check those out. The more that you talk about it, the more people can learn from us and we can educate them, which is why we're doing this. So thank you so much, and we will talk soon.